So we are going to start our session about ocular surface disease. The first speaker will be Dr. Mohammed Ahmed. He's going to give us overview of the ocular surface disease. Please, Dr. Mohammed.
Thank you, Dr. Ashraf, for the presentation. Dear friends and colleagues, it looks like a coffee morning today. We are just a few, so let's make it just a nice chat. Today I'm going to tell you a story. I'm not going to tell you real things. A story of the ocular surface disease, my passion with ocular surface disease. Once upon a time, Einstein said, not everything that can be counted counts, and not everything that counts can be counted. If any example of this straightforward fact, I would say that ocular surface physiology and ocular surface pathology is one of the most amazing things I have ever seen in my medical career. So I started to realize that when I started my fellowship with the Orbis in 2007-2008, I worked with Dr. Woodford Van Meter, and at that time we were doing a lot of keratoplasties. And as our seniors here who have done hundreds and thousands of keratoplasties, I realized that it is different response between one patient and another. And the next day, you might see a crystal clear cornea, or you might see a very edematous one. I start to asking why this is happening. So I start to want to learn more. That's what I did by joining the nice team of Professor Dua in 2010, when I have seen a lot of these very tough cases. The cases which we can see it once or twice a year, you can see it's a full clinic with Professor Dua. A lot of corneal burns, corneal melting, corneal fibrosis, corneal deposit, a lot of amniotic membrane. So then I start to know that how the ocular surface is a complicated environment. We have tear film, we have eyelids, we have cornea, we have meibomian glands, we have autoimmune system running out there. So we need to understand more. That's why, as a problem, the ophthalmological community try to deal with this variety by a systemic way. So they developed some algorithm. There was a standard one, and another which is covering, let's say, 60–70% of cases. A more focused one, which is the ESCRS point of care concept. And there is the wider one, which is the Cornea and External Disease and Refractive Surgery Association. We will have a quick look for each one of them. We all know the DIOS treatment algorithm when we start to grading our treatment according to the severity of the cases. And we all know that in this, we all do it in our clinics, that when we treat several copathology, tearosmolarity, anti-inflammatory, osmoprotectant, we all do this every day. So this is our daily butter and bread. But by developing of the refractive industry, there is a new demand come when you have to satisfy the patient by doing a very good or achieving very good refractive results, where the half diopters matter here. So the American Academy has developed a new approach depending on what we call the point of care. This is for a very focused group, the group of patients who wants to do cornea or refractive surgery, either LASIK, either refractive exchange. And this concept depends on a careful evaluation and delicate evaluation of the ocular surface disease prior to the surgery and prior to making the measurement. And in order to do that, we had a new set of instruments now. We have ocular surface analyzer, which measuring the non-touch tear breakup time. We have the tearosmolarity test. We have MBB9 test. So all of these methods were utilized to evaluate the ocular surface prior to the surgery. Once it is okay, then we can proceed to the surgery. Otherwise, we need to give some treatment. We go and give some treatment and give some time to improve the ocular surface before proceeding for the surgery. And we have to inform the patient that he has a bad ocular surface, he might need some further treatment later on. So that was another story. But because of the major variety of the ocular surface disease, a new concept has come. It's the Cornea External Disease and Refractive Surgery Society, which has introduced in 2017 the new concept called dysfunction tear syndrome. It's a multifactorial etiology with overlapping between etiologies. It is trying to cover the widest range of cases and giving a new approach for the management. So the management depends here on step-by-step strategy, and we use a variety of procedures and utilizing a lot of medicines and methods which might be even off-label. And in this classification, we are having 4 subtypes. We have, example for dry eye, we have aqueous deficiency, blepharitis, evaporative dysfunction tear syndrome, exposure keratopathy, and it introduced a new concept which is called conspirators. It's a kind of cases which mimic the dysfunction tear system, but it is not a real dysfunction tear system, like allergic keratoconjunctivitis, superior limbic keratoconjunctivitis, conjunctivochalesis, Thyroxine, medicamentosa. So in these kind of, it looks like a vague, but when you understand it and try to utilize it, it's quite useful. I'm gonna take a big pardon for Dr. Safwan. I'm gonna present 1 or 2 examples of the cases of the management. So I'm not gonna spoil his presentation, but just having 1 or 2 cases. So this is an example of how we do utilize these kind of cases. We have a 25-year-old female came to the clinic having redness, severe pain. She's a very active young lady who is having an office job and she drives. And she's a chronic use of contact lens user. She's more than 10 years. And when you see her, you see this clinical picture. She has the vision is dropped up to 624 in the right eye, 612 in the left eye. You look at that cornea and you see this ground glass appearance of the cornea, and you see that peripheral corneal opacity, a faint one, and a lot of neovascularization and pannus. So although the center cornea is still clear, but obviously there is something serious happening here. So if we look carefully and try to evaluate the findings, you will find that there is 2 kinds of epithelium covering this cornea, besides the heavy vascularized peripheral area, especially in the superior part. So in this case, you will realize that the chronic trauma has destroyed the barrier. So we need to restore that barrier. I decided to do what Professor Dua called sequential conjunctival scrapping. It's removing the conjunctival epithelium and allowing the normal healthy epithelium to arrive along with medical treatment. This is the recovery after 2nd day. After 5 days, it's almost recovered. On the other eye, I decided to go for pure medical management. So eventually, we can see that after 10 days, everything went back to normal. So we need to understand that. Sometimes it's a little bit, just 2 minutes, it's a little bit difficult to understand, like this case, keratoplasty done in 1 eye, and then they started to develop this strange classification among the stroma. It is covered by the epithelium, by the way. And if you look at this, you can see how it is just made a corneal thinning with classification. In this case, I just decided to debride it slightly and give some treatment. He improved, vision improved, but later on, he went to some other colleagues because he has high stigmatism. He decided to do femtolasic relaxing incision. And unfortunately, there was an opening in the AC, and he has to put a suture, but he came back to me with the same recurrent lesion. If we can see here that, I'm going to show a short video. This kind of lesion, for our senior colleagues, if they have seen something like that, you can see that this is under the epithelium. It's quite hard and tough. You can see that if we try to touch it by a sponge, it is not going to move easily. And if we try to debride it, you can see how the response against the insulin tip. It's quite hard. You remove easily the epithelium, but you can't remove it easily. So to conclude, sometimes we have a complicated etiology for the ocular surface disease, and the management should be depending on many algorithms. It is not a holy book. And then we can learn that clinical management is an art rather than a science. Thank you.
Thank you so much, Dr. Muhammad. And we are going to the second speaker directly, Dr. Safwan Bayati. After we had this very good overview of the ocular surface disease, now we are going to look for the management. And I think Dr. Safwan is going to present how we are going to with this Ferrari.
So good morning, everybody. I thought that Imad, he will help me in guiding me to the fundamental of, and he gave us comprehensive issues related to the OSD, and I'm sure agree with him that the OSD is a big subject and it needs a lot of issues. So here I will go through the fundamental issues, more simple, in a way that we can tackle the cases that we have it practically in our centers, in our clinics, in our sites where we are dealing with the patient. So let us start with the simple definition of this. So ocular surface disease indicate damage to the surface layer of the eye, namely cornea, namely cornea and conjunctiva. There are many causes of ocular surface disease, but here we will touch the most common one, the dry eye syndrome and the blepharitis, and the correlation between them. Now, let us review the causes that some of them Dr. Imad mentioned it, blepharitis, dry eye allergies as a diseases that might lead to decreased tear quality and or production of with the age, chemical or thermal burn, side effect of medical treatment or prescriptions medications, keratitis, Sjogren, and meibomian gland deficiency, the MGD. This vicious circle we are all seeing and all presenting and all showing, because all of them lead to two important causes of the OSD, which is the MGD and the dry eye syndrome. So I will try to follow those two important causes for the OSD in a way that we can reach to a conclusion of a treatment simply according to the stages of the patients that are presenting to us. So the symptoms, most of common symptoms of dry eye syndrome are the dry, gritty or stinging sensation, sand sensation in the eye, redness, mucus discharge, fluctuation of vision, contact lens intolerance. These are raising the flag for us that there is a dry eye. Many of these symptoms can also be caused by other ocular conditions such as blepharitis, inflammation of the eyelid, and ocular allergy. So there is an interaction between those two, and we need to realize and find out which one that creating to the other. Dry eye syndrome are often made worse by activities where patients tend to not to blink frequently, such as the reading, working on a computer or phone, watching television. Dry eye symptoms are also generally worse towards the end of the day. Blepharitis symptoms are very similar to the dry eye symptoms. Blepharitis tend to cause more redness and crusting of the eyelids and congestion with the vascularization of the eyelid and crusting on the side, whether it's anterior or posterior, and the symptoms are often worse in the morning and improve throughout the day when that crust will start to be away from the lid, or the accumulation of the free fatty acid that will be changed from a lipid will be disappeared. So that's why the symptoms, it will improve at the end of the day. Now, for the causes of dry eye syndrome is primarily caused by poor quality of and quantity of the tear. Blepharitis means inflammation of the lid, and blepharitis is often divided into anterior, as we know, and posterior. In reality, many eyes have both form at the same time. The risk factor for the dry eye: advancing age, female, dry eye environment, smoking exposure, connective tissue disorders, Sjogren syndrome, rheumatoid arthritis, conjunctival scarring from prior injury, chemicals or others, as I mentioned in the causes, certain medication, antihistamine, beta blockers, vitamin A deficiency, prior eye surgery, especially corneal refractive surgery, as Imad mentioned. The risk factor for the blepharitis, the development of this MGD, can occur as an either low delivery or high delivery of the MG lipid onto the ocular surface. A high delivery, also termed hypersecretion, result in large volume of MG lipid accumulating at the lid margin, and the hypersecretory MGD is usually secondary to the systemic conditions such as seborrheic dermatitis, atopic dermatitis, and acne rosacea. And what's happening here is that with it, there is some sort of bacteria, Campylobacteria acne, that it changed the lipid to free fatty acid, and this free fatty acid is very irritant and crusty on the lid margin, and that's one of the pathology explanation behind the hypersecretion. The low delivery state is an obstruction that can be further classified into hyposecretion or MG obstruction, and hyposecretion develop when MG atrophy occur, resulting in a generalized reduction in the number of function MG. MG obstruction is the most common form of MGD. With the obstructive MG, there is a hyperkeratinization of the epithelium lining of the MG duct occur. The exact cause for a development of hyperkeratinization is unknown, but inflammatory mediator are suspected. Now, complication, as Imad mentioned, a few things related to them: corneal dry spot, corneal abrasion, corneal infection, scarring, thinning, perforation. The test we have for it's a variable, so I will go through the tear breakup time that I'm depending on it a lot. Schirmer test, corneal staining, tear osmolarity staining, as shown by Imad, in different position, mostly in the lower part. Tear osmolarity with the high osmolarity than 316 milliosmol, it's indicated, it's show a significant that this patient having dry eye resulted from MGD or a dry eye syndrome. Diagnostic imaging like meibomiography that's shown here, it's clearly shown, this one, but unfortunately it's not available with all our center. Now, inflammatory markers, we have a lot of inflammatory markers in tears for those patients that they have MGD or dry eye syndrome. It started from MMP9, interleukin 1, interleukin 6, interleukin 8, interferon, and the tumor necrosis factor. Measuring inflammatory marker in the tear helps assessing the level of inflammation, but it's a non-practical issue in our center. It's very difficult. Now, MMP9, when we are measuring it, it's not a specify for the dry eye, it's non-specific, but we can have it as guidelines for a regression of the inflammation. That's right. Now, MMP9, this is the tools that we can have it in our center to test it, but still I'm saying that it's non-specific, that we can depend on a regression of it. If it's reduced, means that our inflammation is being treated well. Now, the treatment, Imad, he mentioned a few things related to the treatment and how we are treating. So the MGD workshop, it's a workshop for MGD, recommended a severity-based approach for the treatment. It's important to first properly grade the level of the MGD severity based on sign and symptoms and the grade of MGD's secretion stage 1 to 4, as Imad mentioned. And 1 to 4, it's just look at it because this scale or grading, it's very important because our treatment depends exactly on it. We don't need to see a patient with a grade 0 and he's been treated with the Lipoflow and with the Zedra and with all issues. And he's free, he don't have. And grade 4, and nothing done for him except the hyaluronic acid tear, artificial tear. So here, we need to take in consideration the severity. Now, let us say it started from grade 0, all the gland patent, and grade 4, 3 or more blocked gland, with the remaining gland partially obstructed, the MyBOM difficult to express, even with the hard digital pressure. Here, this is a grade 4. So those having different kind of treatment. So stage 1, lid warming and expression is one of the issues that important to state. And what we mean by expression is a pressure, and what we mean by warm is the applying gentle warm compression. So it's a warm compression. Lid hygiene, commonly referred to the lid scrub. That's the stage 1, used to clean the base of the eyelash. Stage 2, I'm just saving the time. Stage 2, the adding to stage 1, the 2-step of stage 1, adding omega-3 fatty acid. There is a lot of controversy here, but I need to put it because MGD workshop, they put it as a part, because that omega-3, that's not proved, unfortunately, that changed the quality of the lipid of secretion of the MG. The artificial tear. Here in stage 2, we need to look at the artificial tear. Which artificial tear that we will use? The one that having only hyaluronic acid, or the one that should have lipid? Here we have a high evaporation. The tear breakup time is very important to test it. If the tear breakup time is less than 10, hyaluronic acid is of no use. There is no use to use the hyaluronic acid only. So we need to use the tear film that having a lipid that protect this tear and prevent the further evaporation. So when any medical rep coming to me saying that, see, I have a tear film with a hyaluronic acid concentration of 0.4, I don't care about that, whether it's 0.2 or 0.4. The evaporation process is the same. I would say something that I have patient with a breakup time less than 10. If I will use this drops and this breakup time change immediately to up to, let us say, for example, it was less than 5 and increase 3 line or 4 line, I will use this drops. 100% it will not increase with the hyaluronic acid alone. So here the artificial tear, the type of artificial tear is very important. Topical and or oral antibiotic. Now, I will summarize here the topical azithromycin 1% ophthalmic solution is one of the important treatment here, and it's present as a drop and an ointment. And all the study shows that it's compatible and the same effect as the doxycycline. Now, the oral, there is a trial to use the oral azithromycin and doxycycline. Sorry for the time, I cannot proceed. The stage 3 and 4, the all treatment that mentioned above and a topical anti-inflammatory. Medication should be also considered as a Zedra and the Liftigrast and cyclosporine restasis. Now, there is a modalities with the stage 4 that can be used, and this is a Lipoflow and the intense pulsed light, and there is a thermal pulsation. Those commercial available units use heat source to either assist with the warming of the lid and or expression of the MyBOM. Now, as I said, the tear film is very important. Our tear film content, that's the content, lipid component and the aqueous and the mucus. And when we have MGD, we have a deficiency in the lipid component, and we don't know whether the mucin is working or not. So my preference is that to use a tear film that covering the hyaluronic acid and carbamide or methylcellulose and glycol and the mid-chain triglyceride. So lipid and the carbamide, so mucin and the lipid to increase the stability and prevent the evaporation. And that will change the breakup time or increase the breakup time immediately and resolve the symptoms of the patient.
Dr. Safwan, 1 minute.
Yeah, this is the last slide. So patients should have a reminder to blink, and this application is present on the Apple. It's an eye protector that the patient should use it, and it gives them a reminder message. Every 20 minutes, he needs to blink 10 times. Thank you very much.
Thank you, Dr. Safwan. Any questions from the audience?
Sorry, I'm leaving because of the time.
Yes.
Just a quick question, Dr. Safwan. You mentioned that sodium hyaluronate doesn't have any role if you have a tear breakup time below 10?
Yes.
So what if it is combined not with the lipid, but with a natural component like xanthan gum or guar or any of the things that increase what we call the PDI of the eye drops, which is the polydispersive index of the eye drops. Some eye drops do have only hyaluronic acid with just a matrix that holds the hyaluronic acid together. Do these eye drops have an advantage over normal hyaluronic acid?
The issue is that what we did is that, as I said, I'm taking
Safwan,
those.
please.
Sorry, I'm taking these here and start to put it on the patient immediately. I have all the samples, and those that they don't have the methylcellulose or the carbamide, I didn't see them that increase the breakup time immediately, unfortunately. So, and the lipid. So for MGD, if you are not covering the lipid and the carbamide, whatever the material other than those, they cannot improve the breakup time. So if you are not improving the breakup time, what's the aim of this?
Naturally occurring material like xanthan gum and guar, and I think the new hyaluronic acid that is cross-linked, I think they do benefit people that do have an MGD as well, without using the lipid component. So what type of eye drops are you using that contains lipid?
Complete.
Is it complete? Yeah, Sustain Complete. Yeah, okay.
The Artilac Complete, Sustain Complete.
Yeah.
Sustain Complete having methylcellulose, Artilac Complete having carbamide instead. The
Okay.
carbamide will work as a mucin part, and the triglyceride and the other lipid will work as a lipid. So the content will be preserved. So the breakup time, let us say less than 3 seconds, it will improve up to 6 or 7.
Okay.
So it's an immediate relief.
Yeah. Thank you.
Thank you.
Thank you very
Thank
much.
you, Dr. Safwan. Now we will have Dr. Tariq Qatamish, well-known professor of cornea. He will talk to us about autologous limbal transplantation in unilateral stem cell deficiency.
Good morning, everyone. I will take you to the other side of ocular surface disease, the nightmare of the end-stage disease of vascularization and conjunctivalization. I will speak about autologous limbal transplantation in unilateral stem cell deficiency. The functions of limbal stem cells, they are to maintain the normal corneal epithelium, and they act as a barrier to prevent conjunctivization of the cornea. The causes of limbal stem cell deficiency are so many, especially the chemical burn is the most common cause, at least in our country. There are other too many causes, systemic diseases as Stevens-Jones syndrome and ocular secretion bifida, and chronic contact lens wear and extensive microbial infection. The manifestations of ocular surface deficiency or limbal cell deficiency: invasion of the conjunctival epithelium onto the corneal surface, conjunctivalization, the thickened, irregular, unstable epithelium, and the formation of secondary fibrosis and new vascularization and inflammation. The treatment options for limbal cell deficiency depends whether the case is unilateral or bilateral. In unilateral case, we have the privilege to have an autologous limbal stem cell transplantation from the other healthy eye. But in bilateral cases, the condition is so bad and complicated, we don't have another normal eye. We have few options whether to do living-related conjunctival limbal allograft from a relative, or to do a keratoליmbal allograft from a cadaveric eye, or to do the ex vivo expansion and transplantation of cultured limbal cells. My talk will be concentrated on managing unilateral cases by autologous limbal transplantation, and I will make a focus on the technique steps. The first part, this is the case of unilateral chemical burn. The first step of the operation, or the first part, is removal of the fibrovascular membrane. So this is the case of chemical burn, as I have mentioned. To remove this fibrovascular membrane, you have to find a plane first, because all these membranes are over the cornea. They are not entangled in the corneal tissue. So you have to be meticulous, and you have to spend some time in finding this plane, and you have to remove all this tissue, and you will be astonished that you will find the corneal surface is very neat and very clear under this membrane. And then you will do a 360-degree periotomy with proper hemostasis to prepare the ocular surface for the limbal grafts. The second part of the operation is dealing with the other normal eye. I usually fashion two limbal grafts about 3 clock hours in the superior and the inferior part of the conjunctiva. Just draw by gentian violet pen, and I have usually make a triangle to point for the limbal cells, because sometimes you may lose orientation. And then you fashion your graft. You have to include about 0.75 or 1 millimeter of the limbal tissue, and then you, by blunt dissection and making BSS injection, you can meticulously dissect this graft, and then you start dissecting it from the corneal side. You may use a crescent knife to very meticulously be very careful not to damage these very precious limbal cells. This is the first graft, and then just to put it over the cornea until you finish with the second graft. The same technique also is done here, and you have to remove the old tenon capsule, and you have to include the limbal cells in our graft, as you see. Then you close the conjunctiva by 7-0 vacuum suture. The third part of the operation is to transfer these two grafts from the normal eye to the diseased eye. You have to open the other eye, and then you catch one graft and put it over the cornea, and then you catch the second graft and put it over the cornea. Notice that the apex of this triangle should be pointing to the cornea. This is inverted, so you have to correct the orientation. So this triangle will help you to orient the limbal cells to be in the proper position. And then you close the first eye. And then we go for the fourth part of the operation by suturing these two limbal grafts. You put the graft and you make the limbal cells over the cornea and put the conjunctiva to cover some part of the sclera. And you start suturing by 10-0 nylon suture. The first two sutures may be somewhat difficult, but when you fix the edge of the graft, the remaining sutures will be quite easy. I usually take about 5 to 6 10-0 sutures to fix the limbal graft. The last part of the operation is to use amniotic membrane grafting. This will help healing, will help quietening of the eye, will help abolish vascularization, will help epithelialization. This is very important to cover the ocular surface with the amniotic membrane graft. Unfortunately, in my country, we don't have fibrin glue. That's why I'm suturing it by Vicryl suture. But of course, if you have a Vibram glue, it will be much better than doing this by sutures. This is the picture after 3 weeks during suture removal. You see how the cornea is getting very clear, and the epithelium is very stable, and the limbal grafts are in place. And if you compare the two, the intraoperative appearance with the postoperative appearance, there's a quite great difference between the two appearances. Another case of autologous limbal transplantation. This is another case of chemical burn, also more advanced, with more fibrosis and with some symblepharon, as you see. Again, you have to look carefully for the aplane, because if you remove this vascular tissue piecemeal, it will leave a rough surface. It's very important to leave a very smooth surface behind you to accept the new limbal graft. So you have to spend some time looking for the proper plane by blunt tip scissors until you find, as you see, by some effort, you will find the plane, and you will leave the eye ready for transplantation. Again, fashioning of limbal grafts. This is another example, the same technique I have mentioned before. Drawing the graft about 3 hours or 7 millimeter, including part of the conjunctiva, and of course, including part of the limbal tissue, as I have mentioned before. Meticulous dissection of the limbal cell is very important. Don't destroy the limbal cells. Be careful not to cut through this delicate tissue. Spread the graft over the cornea. Do the other one, and then go and suture these grafts to the recipient eye. The third part, suturing, the same suturing technique. The first two sutures is somewhat difficult because the graft is loose and mobile, and once you have fixed the first two sutures, the remaining sutures will be very easy to do. And we try to approximate the conjunctiva as much as we can. We don't want to leave too much raw area. And then at the end, we'll cover by amniotic membrane graft. This is a very important step. Of course, if you have fibrin glue, it will be great. But if you don't have, you can suture it by 7-0 Vicryl sutures. Again, the post-operative after 3 weeks during suture removal, very clear and very stable corneal epithelium. And this is the difference between the intraoperative appearance and post-operative appearance. Of course, in these cases, the cornea is clear, but sometimes when doing a limbal transplant, you find the cornea, the ocular surface is stable, but still the cornea is not that clear. So at this time, you may go for keratoplasty, but of course you will have a proper situation and you will be having a great chance of success. So you may end with a clear cornea, or you may end with an opacified cornea with stable ocular surface. At that time, you most probably will have a DALC operation, which is much better than doing penetrating keratoplasty in Charles cases. Thank you very much for your attention.
Thank you so much, Dr. Tariq. Wonderful videos and highly instructive. But just a question. When you take the limbal stem from the cornea and the conjunctiva, okay, yes, can we take only the cornea and the limbus and cut it into small pieces to put it as a 360 degrees yes, on the cornea and then put the amniotic membrane?
Yes, of course. This is the slit technique.
Yes.
But as you know, I am a lamellar corneal surgery. Okay. I am not that advanced ocular surface surgeon. This was a very old videos for me. But of course, recently we can make the limbal cells as small pieces and spread it over the cornea and put the amniotic membrane above them. Yes, I totally agree with you.
Thank you so much, Doctor.
Thank you.
Now we will have Dr. Ashraf Armia, well-known international cornea and anterior surface surgeon.
Good morning. Thanks again for the committee to including me in this session with Dr. Mohammed Hosni and Dr. Mohammed. I'm going to talk about refractive surgery and dry eye. And also I'm going to highlight the neurotrophic and neuropathic keratitis which can happen post-refractive corneal surgery. I have no financial disclosure, but these are my company that I'm consultant to. So dry eye, as we all know, is a common ocular disorder affecting tens of millions of people, and the incidence and the prevalence in Asia is higher than in Europe and North America. And also the common perception of the dry eye disease is one of the single disease primarily caused by decreased tear production. So according to the TAFUS, the DOS2, despite of the various proposed definition of dry eye disease, a single global concerns does not exist, and our discussion about global definition started in 2016, and the active discussion were held 4 occasions based on the tear film and ocular surface disease dry eye workshop. So the final new definition proposed is that dry eye is a multifactorial disease characterized by persistently unstable and or deficient tear film causing discomfort and or visual impairment accompanied by variable degrees of ocular surface epitheliopathy, inflammation, and new sensory abnormalities. So in this very nice scheme, this is everything. If you follow up this huge scheme, you can reach what you want to do. So if you have a patient asymptomatic and symptomatic, if it's asymptomatic, so it's normal, no treatment required. But if it's asymptomatic and no signs, it's like the normal. If there is signs of ocular disease, so you differentiate between neurotrophic condition or signs without symptoms. So if it's a neurotrophic condition, so this is sign indicating dry eye disease required. If not, so the prevention management appropriate as a pre-surgical. If it's symptomatic, so look for signs of ocular surface disease, or if it's symptomatic with no signs, so there is neurotrophic pain, non-ocular surface disease, or symptom without signs like preclinical state. And also, this diagram shows that the ocular surface dryness leads to polymorphic non-receptor mechanoreceptor, which the same as the ocular surface inflammation lead to the same end. And also, when there is a non-receptor happening, so you look for sensation, tearing, and blinking. Sensation, if it's pain, unpleasant dryness, sensation with dryness and freshness, this is for sensation, tearing, basal flow and the reflex response, and blinking, which is the basal rate and the reflex response. So neurogenic inflammation, it's a mechanical and inflammatory damage to the ocular surface, which lead to the senses of neurotrophic factors that stimulate nerve growth, which alter the corneal nerve structure as seen in the subbasal corneal nerve plexus, leading to nerve degeneration, epithelial damage, induction by the hyperosmolarity, and the release of vasoactive neuropeptides and activation of the immune cells, resulting in plasma extravasation. So neuropeptides and neurotrophins, these are new things that we should look for in the last years, found that ocular surface has been associated with non-specific corneal pain and other dry eye disease. Again, neurogenic inflammation. It's a neuropeptide maintain the neurogenic inflammation and work together with the immune response, not only protecting the ocular surface, but lead to immune response in dry eye disease and regulatory its chronicity, which lead to nerve deprivation factors, can both attenuate and amplify the dry eye disease. Is neurogenic inflammation related to sex? Yes. They found that the hormonal variation may also affect the ocular surface disease. And studies in animals have reported that the estrogen may regulate the MMP2 and MMP9 and increase the expression of inflammatory genes such as the interleukin A, beta, and 6 and 8. And by contrast, the androgen may reduce the macrophage. However, some studies have found that the estrogen also may decrease the dry eye disease severity. The neurosensory abnormalities. We should look, it's not a refractive surgery per se. The human cornea is densely innervated and the cornea nerve participate in the stability of the ocular surface. So neurosensory abnormalities may participate in these different, but closely related to the mechanism of dry eye. In the next one, so if we are going to evaluate a dry eye before refractive surgery, it's very important to diagnose if there is a dry eye before refractive surgery, because we are going to see now how refractive surgery can affect the nerve fiber, the corneal nerve fibers, and increasing the effect of dry eye if it's before the refractive surgery. Very important that when we diagnose dry eye, as Dr. Safwan said, it is not a single factor. So before corneal refractive surgery, special attention should be paid to people with especially myopia who have long diopteric value and contact lens wearer for a long time. These are prone to dry eye more than the other people. And if necessary, dry eye screening should be performed. For patients who are clearly diagnosed with dry eye, the medication should be carried before any refractive surgery. So, poor performance on Schirmer tests, less than 10 millimeter is a significant risk of factor of the eye disease. Lisman green and sodium fluorescence staining to identify ocular surface disease. Sodium fluorescence also identifies areas of discreted or injured cells where there is ocular surface disease. And the sodium fluorescence is difficult to photograph, but the Lisman is more nice and you can see it perfectly more than fluorescein. Also very important, the meibomian gland assessment. It's very crucial before any refractive corneal surgery, because it's very important, either LASIK, fem to smile, whatever the procedure, everything can cause dry eye. Yes, the lenticular extraction is less dry eye because the less cut of the corneal fibers, but it can happen if you already exist in a dry eye. So during biomicroscopy, assess the appearance of the lid margin, very important, and to identify the scurf, depress, and scalloping, and the neurovascularization, which is very important. Apply pressure. All patients should apply pressure on the lids to see if there is any expression of a meibomian gland or not. This is a crucial test. Crucial test. Does the epithelial mapping changes in dry eye? Yes. And the studies. This is a very nice study by the Royal College. It was recently published, and they said that the corneal epithelial thickness profile in dry eye, it changes. This is the normal picture, and this is the abnormal, the dry eye picture, and it completely changes the thickness of the epithelial maps in the areas where there is a dry eye disease. It's different than the normal areas without the dry eye. This is also another very nice study that said that the prevalence and signs and symptoms of dry eye disease, they discovered from 5 to 15 years after refractive surgery. They concluded that the osmolarity difference suggests that a significantly high prevalence of dry eye disease in patients who had corneal refractive surgery, even after 15 years, is still present. And also another study suggests that the impact of corneal refractive surgery on the precorneal tear film. So it's not just a corneal refractive surgery. And this very nice scheme, it was from a very nice article, and they give this huge diagram about corneal refractive surgery. Corneal refractive surgery, damage to the corneal nerves. So dysregulate the tear secretion from the lacrimal gland, and it also alteration in the corneal morphology and thickness. So all this will lead to dry eye. So it's not just a corneal refractive surgery. You are damaging a lot of the cornea in the corneal tissue. And also in the last, I think, 4 or 5 years, this title, the neuropathic corneal pain, appears highly because we found that a lot of people we did the refractive corneal surgery, everything is fine, the patient is seeing good, but he is always complaining of pain and photophobia, and you cannot know why this is happening. And this is why, because you did a neuropathic cornea injury of the cornea. So dry eye disease post-LASIK is better described as it is a spectrum of disease that includes tear dysfunction and neurotrophic keratopathy, and the presentation of subset of the patient has come to be known as a corneal neuralgia. This term is becoming high in the last 5 years, corneal neuralgia after LASIK, corneal refractive surgery or LASIK. And also in this article, it was 2021, they said that the neuropathic corneal pain following LASIK surgery, mainly in Asian or the Caucasian, or found that the fibromyalgia and other functional eye syndromes, autoimmune diseases, and the thyroid disease are some of the other systematic diseases that can lead to dry eye disease and neuropathic corneal pain following LASIK surgery, the risk factors. If there is a corneal new mediators, yes, all these mediators can happen and increase after corneal refractive surgery due to the injury of the corneal nerves and epithelial and stromal changes. And also, this is a very nice scheme out about all the new mediators that can be released after corneal refractive surgery. So, corneal wound healing is associated with the post-operative refractive stability, predictability, visual function, and result in the patient satisfaction. And the healing process of corneal refractive surgery is a complex procedure between cells, neuromediators, and cytokines. And the changes in various neuromediators are observed following LASIK or PRK or lenticular surgery, whatever the procedure you are going to do. So, for sake of time, so again, corneal injury, damaged corneal nerves, triggers inflammation, neuroinflammatory, and the wound, and also alter the wound healing of the cornea. And if you compare between PRK and LASIK, yes, PRK had the greatest increase in the immediate and post-operative period following healing from day 1 before decreasing up to 1 week, but in LASIK, lower the new growth factors ratio compared to the PRK procedure up to 1 month. So at 6 months, both procedures are close to each other. And also, if we're going to compare between LASIK and SMILE, so changes in the neuromediators in both, yes, in SMILE, it is better than in LASIK. I'm going to skip this. So, the conclusion, I'm not against corneal refractive surgery, but you should know that dry eye syndrome are commonly reported after either LASIK, whatever, or any refractive surgery. However, it is a rare presentation, yes, and the pathophysiology of this condition remains unclear, and the prevalence of the neurotrophic pains that happen after LASIK, it's a rare situation, but it can happen, and you should be aware of it. Thank you so much.
Thank you, Dr. Ashraf. Dr. Ashraf, I want to ask you, after the famous case when some journalists commit suicide after refractive surgery in the United States,
yes,
people become more aware about this. In our real-life practice, we do see patients who having very severe symptoms than the signs you are seeing or you are evaluating. And on the other side, you can see vice versa. You can see people who have very severe signs, but they are not complaining at all. In real life practice, do you refer those cases with neuralgia to psychiatrist or to someone for the pain management or no?
This is why this presentation, because you can find your patient clear, 6'6", and you cannot find any signs that explain his complaint. So neuropathic pain or neuropeptide that appear after LASIK surgery is one of the most explanation of this condition. And in the state, they have the MMP factors. They can test it, and they can. We don't have this in Egypt, I know, but they can test it, and you see the value of it, and you can explain if it has a neuropathic pain, neuralgia. So if a neurologic pain or neuralgia, you should prefer it. You should refer the patient to a pain clinic. That can help a lot in these patients.
That's the point behind my question. I just want to highlight this to my colleagues that sometimes we don't hesitate to send him because it might be serious.
Yes.
One final question, because we have some time. Do you think that SMILE has less effect on neurotrophic?
Yes, I put
you put the comparison between PRK and LASIK.
The second slide was between LASIK and SMILE.
SMILE.
Yes, this is true. In lenticular, lamellar, lenticular extraction, yes, the neuropathic pain, as approved in this paper, it was 2021, and they said that the lenticular extraction, less neurotrophic pain and less dry eye than the LASIK, because it is the area you are going to cut, the corneal nerve fibers is less. But the corneal nerve fibers does not relate it only to the area you are going to cut on the corneal area, but also in the stroma, because you are going to remove part of the stroma in the lenticule, so it also related to the part of the corneal nerve injury. But the study said that the lenticular extraction is less dry eye symptoms than the normal classic LASIK.
I would agree regarding removal part of the cornea will affect, but the recommendation of going a little bit deep to make the cap around 135 will spare the majority of the superior plexus and reduce this effect.
That's true.
Thank you, Dr. Ashraf.
Ashraf, just a second. I wasn't going to comment on this, but the lady who committed suicide in the US did a SMILE, not LASIK. So this was a very famous case of neurogenic pain post-SMILE surgery. The other thing is doing a cap more than 135 does compromise the biocompatibility of the cornea. So again, this is on the boil, and the research is not very, very ripe yet. The final thing is, it really differs from one country to another, because I've been doing refractive surgery, lamellar refractive surgery, surface refractive surgery over the past more than 2 decades in our part of the world. And honestly, I can say that the emphasis of post-operative dry eye is not as significant in Egypt, for example, as reports come from other parts of the world. I have yet no patient that I've sent to a pain clinic after refractive surgery over the past 25 years. So I think this is something that is there. This is something that can pop up every now and then in some places in the world, but there's no like an active cohort that you can say that this procedure will produce much more neurogenic pain than the other. It's all just predictions, and it's all just it's not evidence-based, but it's theory-based predictions. But you cannot. We do not have like 200 patients that have neurogenic pain, and we can subdivide them into different procedures. There's no study in the literature up to this very moment. So I know Ahmed is a very big fan of SMILE, and that's why he threw this small comment. But again, until now, there's no evidence that neurogenic pain, not dry eye, neurogenic pain can be protected from by doing lenticule extractions.
Yes. This is true, and this is the same. The study said the study that yes, this can happen, and this can happen in SMILE or LASIK. The same. Maybe it's little bit less in the SMILE. Like it does not. It can happen in SMILE. Yes, can happen in SMILE.
Just one final comment on Dr. Muhammad's comment. Maybe in the geographic variation, the environment for sure has a significant impact. For example, in this part of the world, we practice in UAE and in the Gulf in general, we have the sun is more tough here. AC is 24-hour, and we see this whole environment will make the ocular surface more fragile in general than in other parts of the world where the weather is more nice and the sun is less. So that's why we tend to see some severe impact after surgery here in this part of the world, different from in other parts where the environment is different. Okay. Now we will move to our next speaker. Our next speaker, Dr. Parol. She will talk to us about the glaucoma with ocular surface disease.
Very good morning, everybody. The aesthetics and grace of a ballerina is just like comparing to a very well-controlled glaucoma patient. But do we know what goes behind? I'm sorry. Can you please help me with this? What a ballerina goes through is what our ocular surface goes through with all the multiple medications the patient puts for years and years on end. This is what happens to the lid margins, to the adnexa, and that's the price a patient pays for your so-called successful medical management. So I'll be talking about the ocular surface disease and its effect on glaucoma. As glaucoma specialists, we are usually focused on measuring intraocular pressures, having a look at the optic nerve head, getting the visual fields done, looking at some numbers on the visual field indices and the OCT, and what we usually fail to look at is the ocular surface on each visit. We know from different papers that there is close to 50% of our patients who are having glaucoma drops are having ocular surface disorders, and this severity increases with multiple medications as we go on, adding more and more drugs to control. Glaucoma is more prevalent also in patients with ocular surface disease, and the prevalence of glaucoma in patients with severe ocular surface disorder is close to 2/3. Now, both of them have a very similar spectrum, so let's just have a look at the similarities between the ocular surface disease and glaucoma. Both are chronic diseases. They have a mismatch in signs and symptoms. The methods of assessment for both vary amongst different clinicians across the globe. The diagnostic tests and their interpretation are also variable across the globe. And there is no conclusive treatment strategy which patients with glaucoma on different anti-medications follow for addressing the ocular surface disease. The treatment is often complex with multiple medications and different preservatives and variably effective. It requires a very diligent care, and neither of the disease will be fully cured, and the treatment is just palliative. So we have to remember there are two different concepts. One is glaucoma therapy-related ocular surface disease, and the other is a person with ocular surface disease which has been exacerbated by glaucoma. So what is glaucoma therapy-related ocular surface disease? It's actually an imbalance of the ocular surface homeostasis, which has been caused by the toxic effect of chronic topical medications, the drug per se and the preservatives, both, which leads to a tear film instability and disruption and results in epithelial damage and a vicious cycle of inflammation. The patients will have common complaints which we often ignore. They just complain of a constant ocular discomfort, a desire to keep rubbing their eye, blurred or foggy vision, and constant dryness. Now, this is something that we are not really focusing on as glaucoma individuals. We are very happy looking at a 12 or a 14 pressure, a stable visual field, and an OCT, and that's where we go wrong. So why we should be concerned about ocular surface disease? Because we need to remember that eventually once the drugs stop working, you will have to consider surgery, and multiple drugs that we have been putting for years and years on end on our glaucoma patients would definitely compromise the ocular surface and eventually result in the failure or a compromised outcome which we are expecting with this surgery. It reduces the reliability of the diagnostic tests as well as reduces medication compliance, poor surgical outcomes, as I already mentioned, and decreases the quality of life of our patients. Don't overlook the signs. I think conjunctiva is something that needs to be stained and looked at each visit, because that's going to provide the answers to a lot of our patients' troubles. When you're looking at enrolling a new glaucoma patient in your clinic, you need to recognize a pre-existing ocular surface disease. Just before you stain the patient for doing an intraocular pressure, just stain the conjunctiva with lissamine green or whatever you're comfortable with, and look at the conjunctival health and tailor-make your first prescription accordingly. So you check the corneal sensations, check the T-BAT ocular surface staining, do a Schirmer's, and check the delayed clearance from the tear film. For patients who you have been following up from over a period of time and who are on medications, every time look for the subtle changes that are happening in the conch, look for hyperemia, chemosis, any evident lid edema, do evert the lid, look for any punctate epithelial erosions or any form of punctate epithelial keratitis. Filamentary and areolar keratitis patients will anyway be screaming with discomfort and you will be able to recognize them. But all this happens with even the most docile anti-glaucoma drugs. Lid margins is not what glaucoma people look at, but these scream for attention, and Dr. Arme has also shown that the lid margins, they answer a lot of your patient's troubles. So you look for meibomian gland dysfunction. The different and multiple medications, they can cause excoriation of the lid margin. You can have neovascularization of the eyelid margin, and do consider lid function, because blink can be compromised in patients with glaucoma. Well, who's the culprit? You can just blame it on anyone, because nobody has been able to pinpoint it for any particular drug or preservative so far. The only thing is that you be watchful. You tell your patient to note what has happened to their eye after they have started a new medication or you've added on something new. Giving an artificial tear or a lubricant on top of the drugs that they're putting is not going to solve this problem. So this essentially is an IgE-mediated response. You can have allergic conjunctivitis and dermatitis with all the drugs. And although prostaglandin analogs are blamed for all the troubles, but beta blockers, I think, are the worst, and they need to be given with a long list of possible adverse effects. So how can you just save the eye or make it easy for the ballerina to have a flawless dance? So you address the problem. Of course, we give artificial tears, prefer preservative-free. Any other medication also switch to preservative-free options. Cyclosporine does help, but you need to tell your patient that don't expect wonders once the drug is added. You need to wait for a few months for the correct action to ensue. Look at the lid margin. If you need to give warm compresses or do address the MGD with different forms of therapy that are available, you need to do that. Lid scrubbing to scrub off any residue of the different medications that the patient is putting, or any blepharitis that has ensued because of the drugs needs to be done. Oral doxycycline, I usually give it with patients who have very severe ocular surface disease, and I've seen that a couple of weeks therapy does help them. Omega-3 fatty acids, I think it helps the ocular surface and helps in regeneration of the goblet cells. Punctal plugs are a double-edged sword, so very, 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 and you have to choose your patient very cautiously when you want to address this. So coming over to the next entity, which is the ocular surface disease exacerbated glaucoma, well, these are those patients with severe ocular surface disease who also have glaucoma that is refractory to medical treatment. They're also more likely to have a compromised success during glaucoma filtering surgery by virtue of the very inconspicuous inflammation that has been smoldering in the subconjunctival space, and that will eventually result in scarring for glaucoma filtering surgeries. Even patients who are undergoing MIGS are not immune to it. So severe inflammation in these patients has been seen with or without anti-glaucoma medications, and those who have been on multiple medications, they have excessive amount of inflammation. So elevated intraocular pressure in patients with ocular cicatricial pemphigoid has been noted, and this OCP has also been seen in many patients of glaucoma, and it could be related to vascular etiologies, inflammation of the trabecular meshwork, inflammation and scarring of the episclera and sclera following prolonged medication. And that can eventually result in compromised outflow. So in this study, what they did was that they just had a look of the pressures when the patient was on preservative the anti-glaucoma drugs with preservatives. They just gave steroids, addressed the ocular surface inflammation, and as you can see, the pressures came to normal range in all the patients. So just addressing the surface inflammation brings down the pressure to a normal range in those who are actually having OSD exacerbated glaucoma. So the factors that result in post-operative dry eye disease or ocular surface disease are variable. As you age, there are hormonal changes that happen, environmental factors that we already talked about. These days, there is so much of dryness which has been induced by air conditioning, and if you go out, the weather makes it worse. Systemic drugs and systemic medications, diabetes, other autoimmune disorders, MGD, and ocular surgery, they all contribute towards a worse outcome in patients with glaucoma and ocular surface disease. Now, when we compare ocular surface disease in patients who have undergone a filtering surgery vis-a-vis medications, we find that the failure of filtering bleb and conjunctival scarring is quite common in patients who already had a compromised surface. The dysesthesia in the bleb adds to the ocular surface disease. So posterior flow, much flatter blebs is something that we are looking at. So it's better to intervene early in patients with glaucoma rather than having them to put medications for very long. If you have a patient with early glaucoma, do consider MIGS. And otherwise, by the time the patient has entered the moderate grade glaucoma, I think it's a good time to intervene surgically rather than to just having them linger on with medications. BAC is to blame for most drugs, but now we have many drugs which are BAC-free. So just choose those drugs. Although your patient at times may complain of having to pay a little bit more if they don't have insurance when they're using preservative-free drugs, but I think we need to tell them that over a period of time, their quality of life would be way better spending an extra buck. Now, dry eye disease in patients with functioning filtering blebs after glaucoma, we have known that microcysts that are formed in trabeculectomy are good, so a microcystic bleb is a good bleb. But these microcysts, they produce abnormal goblet cells. They have an abnormal mucin, and that is not very healthy, and that even if the bleb is functioning, it still can contribute to an ocular surface disease. The bleb height and the bleb corneal angle also contribute to a dysesthesia and an inconvenience when the patient has such a high bleb. So address the patient's inflammation in the early postoperative period so that you don't have an acute angle of the bleb with the corneals, with the sclera. You have a small bleb corneal angle can induce tear film instability via the same mechanism as I already talked about. So address inflammation at all levels. Even glaucoma drainage devices, they produce Dellin-like keratopathy, which can be very, very inconvenient for the patient. So no notice is taken of a little evil. We don't know that a little bit of ocular preservative drugs, which are there in our anti-glaucoma medications, are making a very compromised quality of life for our patients. So you have to address all these issues in the earlier stages of glaucoma if you want your patient to be happy and have a good surface. Thank you.
Thank you so much, Per. It was a very nice presentation, but I'm going to just a question. If you have a very severe dry eye and that you have a conjunctival problem when the tenon is nearly atrophic, do you go for penetrating or non-penetrating, or you are going to shift your decision that you go for ab interno for any kind of operation, not to use this nearly atrophic tenon and the conjunctiva, and it's going to affect your results in penetrating or non-penetrating glaucoma surgery?
I would like to defer such a patient for as long as the entire inflammation is settled. So I would give steroids. I usually give steroids in very inflamed eyes. And I try to change the site. So usually we prefer a superior site. And all the drugs, once the patient is putting, they just trickle from the superior surface down to the inferior fornix. So I would prefer a more temporal lesion where the tenon is relatively more healthy. But for me, tenons is really sacrosanct because that's what makes the entire surgical area more physiological. So if you have a compromised tenon, you're going to have a compromised postoperative outcome sooner or later, a thin ischemic bleb or a thinner surface. So address it with inflammation. Let the anti-inflammatory drugs, be it steroids or be it NSAIDs, just let it settle and then just go ahead for a surgery, maybe at a different site.
This has been an amazing presentation, so thank you very much.
Thank you.
I just have a couple of questions. You're using steroids. Usually glaucoma specialists hate steroids. So my question is, do you use a specific type of steroids, i.e. loteprednol, because it does not...
Low-potency steroids a week prior to the surgery or a couple of weeks prior to the surgery.
So you're going for fluorometholone-like steroids or loteprednol, which is very strong on the ocular surface, yet does not cause any steroid response glaucoma-wise?
Preferentially, I use fluorometholone in my patients.
Lotemax.
Maybe twice or thrice a week.
Yeah.
In patients who are not steroid responders. So establish that prior to starting a steroid that your patient is not a steroid responder. Okay. That's one. I also start cyclosporin in these patients. We do get to know that eventually this patient is coming closer to the need for a surgery. Preemptively start counseling the patient. Preemptively switch to preservative-free drugs if they have not already been putting them, cyclosporin, and then add a fluorometholone type of a steroid for a couple of weeks to see how ocular surface is. Once the superior conjunctiva is sort of less hyperemic, take a step and go ahead. And even on the OT table, I make sure that there is a meticulous closure. I'm not too brutal when I'm using the instruments so that the conjunctiva and the tenons are preserved. Because the tissue respect, if it is maintained, there is less postoperative inflammation. And you can go a little overboard with your steroid medication in postoperative period to sort of take care of it.
So my second question is, we know that glaucoma patients, their eyes are marinated in preservatives for a long time, for years and years. I'm actually involved in a study which is under publication now comparing preservative-free medications with preservative medications. My question for you is, we all have the inclination, we're all cornea surgeons, so we come from cornea land, so we all have the inclination not to use prostaglandin analogs in patients who have OCPs or MMPs. But then came the new era of prostaglandin analogs, i.e. tafloprost. Do you use tafloprost in patients who have, even if you have it like preservative-free, would you use it in patients who have an ocular surface inflammation or no?
Yes, but there we take it with a pinch of salt because the efficacy of saflutan or tafloprost is not as well as a travoprost or a vimadoprost. So yes, you have to consider adding another drug. But so if you are compromising by a little less efficacious prostaglandin analog as tafloprost, and you have to add another drug to make it equally efficacious to, say,
but you would use a prostaglandin analog and you're not afraid of upregulating the inflammation on the ocular surface?
Well, that's why it's a very precarious balance, and you have to.
Yeah, I know. That's why I'm asking you.
There is no perfect answer to it.
Okay.
I mean, most of the patients that have started just on a tafluprost have not really done as well as I would have desired. But then you can add on a selective laser trabeculoplasty or do a SLT first and then add on a taflutan to address that issue, to take you to the desired range.
Thank you.
Right, thank you.
How much the severe dry eye or ocular surface disease affected the Ahmed valve or any other valves like the Beverly? Is the same success rate like the penetrating glaucoma surgery, or it does not depend a lot on ocular surface disease in cases of Ahmed valve or Beverly valve or any valves in this severe ocular surface disease?
The image I showed you is an ADI device. That's an indigenous device from India, which is essentially like a bar weld. But I otherwise personally use Ahmed because I find a very huge bleb with Delin, with ADI, or with the bar weld. So I am more happy with an AGV, and I think AGV gives a better outcome because you can use a hangback technique and put the AGV plate a little further. So the primary and the secondary capsules that form with the Ahmed valve are much more subtle. They are not as pronounced. They are a little away from the very visible ocular surface, and they don't cause as much disturbance.
And how much it affect the ocular surface disease for the success of Ahmed valve?
Well, nobody uses an anti-metabolite when they are using a valve of any type. So I don't think that a lot of us consider ocular surface disease by the time we have reached a point when we are using a valve. But essentially, I guess that the secondary capsule that forms on the bleb plate, the time of formation of that capsule is influenced by ocular surface disease. And the earlier the capsule forms, the more precarious is your post-operative outcome post that. So addressing ocular surface disease pre-surgery would lead to a better outcome.
Thank you, Doctora.
Thank you.
I think we still have another 3 or 4 minutes. If anyone of the audience has any comments or any question for the speakers.
Okay. So thank you so much for all the speakers and the panel, Dr. Mohammed Hosni and Dr. Mohammed. And thanks for the audience who came early in this day. Thank you so much.